All right. Hi, I'm Kathleen Gallant. I live in Pittsburgh, Pennsylvania in the U.S. I'm on the board of the International Federation of Psoriasis Associations, and I'm also with the National Psoriasis Foundation as the liaison to the International Federation. I'm a psoriasis patient. I've had psoriatic disease since 1977, and I've been disabled with psoriatic arthritis for 30-some years. So I'm looking forward to having this discussion with you, Dr. Coates, on the GRAPPA updated guidelines and how we as patients can use these to better our conversation with our healthcare providers.
Sure, thank you very much. So my name's Laura Coates. I'm an associate professor at the University of Oxford, and I also work as an honorary rheumatologist here in Oxford as well. And I'm here today for this interview, partly because I was one of the co-chairs for the update of the GRAPPA treatment recommendations. So there were three of us, one from Europe, one North America, and one South America, who co-chaired the latest update of these guidelines, which have been around now for about 15 years.
Great. So can we just start out, Dr. Coates, by talking about what are the key updates to the GRAPPA guidelines?
Yeah, so I think the guidelines this time have not changed hugely from 2015 in terms of the specifications and the aim of the guidelines, the overall approach. But obviously in that last 6-year period, we've seen a big increase in the number of medications available for psoriasis and psoriatic arthritis. So it was really important to us that that update would encompass new data. We've got more data on some old drugs as well, so that has resulted in some changes in the guidelines, even for old therapies like methotrexate that have been around for many decades. But I think probably the biggest change is the availability of new mode of action biologic drugs or targeted synthetic drugs that we need to include into our treatment algorithm.
Oh, great. How does this approach differ to how patients would have treated their disease before these came out?
So I think we've got more options, and that's always useful. So we had good drugs in the last update 5 or 6 years ago, and a lot of those drugs are still being used and would still potentially be our first option. But the thing about psoriatic arthritis is that no two patients are the same. So we see patients with different manifestations of their disease in terms of how bad their skin is, whether their spine is involved, whether their tendons are involved, which joints are involved and how many. And then we see a lot of associated conditions in some patients as well, like inflammatory bowel disease or inflammation in the eye causing uveitis. So there's a lot of things that we take into account when we're choosing a drug for an individual patient in front of us. And sometimes that can be quite tricky. And as I'm sure most patients will recognize, this is a long-term condition, and not everybody keeps responding to a drug when it has worked for them for some period. Often we have to switch medications, try something new. And so having more options available for those patients, maybe not as a first drug, but as a second or a third drug is really important as well, to have more options in our armamentarium. And we're also seeing some improvement in efficacy, particularly for the skin. Some of the newer drugs that we have available now are significantly better than some of the older biologics as well.
All right. So do you think these new guidelines will impact healthcare professionals?
So it's always difficult with guidelines and recommendations to know how much they impact. I think they are very useful, and particularly the feedback we get from clinicians is around those difficult decisions of choosing a drug for an individual. So we put a lot of effort in these recommendations into comorbidities and related conditions. And that's often where there isn't so much data in recommendations. So I think that's really helpful to know when you should pick different drugs for different individual patients. Obviously, I would expect that most clinicians would be aware of these newer therapies, that we included drugs that are currently available, so they're licensed and clinicians will have heard about them. But I think it's providing a bit more context, a bit more advice about those individual drugs, when they're particularly useful, any contraindications they might have, and how you might choose a drug that's really useful in the recommendations.
So then what is your advice on how healthcare professionals should use them?
So I think they're there as overall guidance. They don't tell you the answer. I'd love it if they did, but that's very hard to do. So these are international recommendations. They have to be applicable in many different healthcare settings, and the access to drugs and availability of drugs differs a lot across the world. So there is a lot of flexibility in the guidelines because we know that they have to work in different healthcare settings and they have to work for different patients. But what we've done, which I think is really useful, is we've summarized which drugs work for the different domains of psoriatic arthritis. So which drugs work for peripheral arthritis, for axial disease, for skin disease, for enthesitis. Then we've also included which of those drugs also work for the related conditions, uveitis and IBD. So you don't have to ring a gastroenterologist, look for guidelines from other diseases. That's included in our guideline already. And then we've got specific advice around additional comorbidities as well. So hopefully those summary figures and the more detailed text will help people to pick out the best drug for that individual patient in front of them in clinic.
Great. Well, this is a question I always struggle with. Can you give advice for patients on how they can broach the subject of the updated guidelines with their physicians? Often I often feel like, well, how do I tell my doctor, this is what you should know? It's not a comfortable subject.
Yeah, so I think it's a balance, isn't it? I can see why patients would feel uncomfortable and why that might be a bit of an issue in terms of bringing that up. I think I've had patients who have quoted guidelines to me and been aware of guidelines. I'm happy to discuss them. I think it's more about access to treatment. So these guidelines don't necessarily change somebody's ongoing care. If somebody's on drug and doing well, then I wouldn't change anything. I would stick with what drug is suiting you already. I think it's more a question around access and availability of other drugs if you need to switch or if you need a new medication. And then it's just asking about what the options are. You don't necessarily have to quote a guideline for that, but just to say, actually, this drug that we've already tried is now not working. What are the other options that I have available to me? And obviously we know, again, this varies in different countries, that different patients will be aware of different medications. So in America, you do have direct-to-patient advertising. So people will be aware of drugs from TV adverts. In the UK, that's not allowed. So there's no direct-to-patient advertising allowed. But we know that people hear about drugs from family members, from friends, from Facebook psoriatic arthritis groups, from other social media. So there's a lot of information out there, and that's a good thing. We want patients to be informed and to understand about the different drugs. And I think it's just having that open conversation. Actually, if somebody says you can't have that drug, why is that? Is that because it doesn't work for your particular disease, or there's a good contraindication why? Or is it because it's not funded for some reason in your country or your insurance provider? And I would have no problem with discussing any of those things with a patient of mine. So it's just being open and saying, well, what about this drug? Do you think it would be good for me? Or actually, have you got a better idea? How do they compare? And sometimes where we have multiple options, then we should be involving patients in the choice. Actually, I've got 2 or 3 different drugs, which I think would all be just as good for you as the others. So would you rather have a daily tablet or a fortnightly injection? Or would you rather have an injection that stings a bit more, but is less frequent? There are lots of discussions you can have. That's not always the case. Sometimes there's a really good reason why we want you to have a particular drug, in which case I'd explain why. But oftentimes there are multiple options. There's not a right answer and a wrong answer. It's just that there are different answers that different options that we could try. So it's just discussing that, I think, and asking why, and what does the clinician think, and what does the patient think about that? And that's what we should be aiming for in terms of shared decision making, so that we're all aware of why we're making that decision, from the patient perspective and from the medic's perspective.
Great. Well, thank you so much. We really appreciate, I'll say that on behalf of all psoriatic disease patients around the world, we appreciate your work on on the guidelines and updating them. And IFPA is going to do everything that we can to push the information out to make patients aware. And hopefully we'll just continue the conversation.
Sounds good. Thank you very much.